Welcome to our next session. This is called Under the Dome. We've been doing this at AAKP for about the past 7 years. And the purpose of Under the Dome is to bring together some of the top lobbyists and government affairs professionals in Washington, D.C. to break down certain issues that are going on in the U.S. Congress, either currently or issues that are building a broader constituency and congressional consensus. We found this session very informative, not only for our own planning, but for many of our activists around the country. This is a fun session, and it gives you some of the practical knowledge that you need in order to be able to do regular congressional contacts, participate in congressional days, and those types of things in the months to come. We always have a great lineup of speakers, and that's no different this year. Really a very good bunch of friends and folks that work with us quite closely at AAKP. Our next speaker is Rob Blaser, who's a longtime friend of AAKP. He's received numerous awards from our organization, and you probably know him quite well as the Director of Public Policy for our friends at the Renal Physicians Association. Rob is an unusual character in Washington, D.C. In this sense, he keeps his sense of humor about all things that he does, and he's quite passionate about the work that he does, not just for renal physicians, but most importantly for patients. He has an encyclopedic knowledge of the legislation, the regulations, and the practical implementation of things like payment models, of how regulations governing care and quality are implemented. And so as he takes a look at different issues that are going on in the Congress, he's very proactive in alerting us to things that we should be aware of 8, 10, 12 months down the road. He's a solid partner to us and somebody that we trust immensely. So go ahead, Rob, take it away.
Hi, I want to thank AAKP for inviting me to their 5th Annual Policy Summit. I'm Rob Blaser, Director of Public Policy for the Renal Physicians Association. I have a lot of slides to go through in a short period of time, so I'm going to be talking fast, but all of my information, contact information, will be available at the end of the talk, so feel free to reach out to me when you're done. What I normally like to do is give an overview, so we will talk about where we were last year, urgent fall 2022 legislative priorities, RPA's legislative agenda, a Part B reimbursement, and some other legislative initiatives. On the regulatory side, we're going to talk about the recent Supreme Court decision, kidney payment model implementation, the immunosuppressive drug rule, the payment rules, and telehealth and Medicare. So where were we a year ago? A year ago this time, the administration was hurting overall because of the perception of the Afghanistan withdrawal and the beginning of the budgetary and inflation concerns. On the regulatory side, CMS Administrator Chiquita Brooks-LaSure was now fully on the job now. She started in May of 2021, and the vision of her leadership was beginning to emerge. There was welcome quiet after some tumult with the kidney payment models early in the year. They had been delayed, so I think people that were involved in the payment model process were happy that there was quiet and they could adjust to things. And with regard to organized medicine, they were having their annual concern with regard to physician payment. In recent years, CMS has proposed cuts, so organized medicine has to go to Congress to try and get the cuts fixed. With regard to the state of play in D.C., toxicity is now something of a way of life. Everyone knows there's exceptionally tight margins in both the House and the Senate, and this is really complicating the effort to get legislation passed. Example of this is the Inflation Reduction Act from this summer. However, the bitterness is somewhat limited to the massive issues that are out there. There's a lot of bipartisan support on smaller topics. This is standard operating procedure, or SOP. Progress on gun control and the chips are hopeful signs for cooperation. With regard to the what's going on with the election year, the compressed calendar, November is likely to be very crazy, and we still have a lot of huge issues outstanding, such as government funding for next year, ongoing support for both Ukraine and COVID, and closer to home, physician reimbursement and telehealth. So, of course, the Biden administration had their high highs and their low lows in their first 18 months. And, there's a theory out there that says an administration's second year is when the regulatory cards get played. It might be less true for the Biden administration because they hired a lot of old hands, but it's still out there just the same. Health equity is being emphasized in all policy making, and this was really true from the first rules that came out from the Biden administration. Organized medicine, for its part, is focusing on health policy objectives with a lot of bipartisan support. They want to do a massive rework of the Medicare fee schedule to address the ongoing budget neutrality issues that are causing the yearly problems, but this is a big lift, and I'll discuss that a little bit more later. And last year, the director of the Innovation Center, or CMMI, Liz Fowler, said that CMS was exploring more mandatory models like the mandatory kidney payment model. Indicates the voluntary models aren't a very true measure of what they want to find out about how payment models works. This doesn't seem to affect anything that's going to be in kidney disease, but it's out there just the same. So the two urgent policy issues for RPA and for a lot of organized medicine and kidney medicine this fall are HR 8800, the Support Medicare Providers Act of 2022. And this is the bill that's been out there annually now to make up for the shortfall in the Medicare fee schedule. There's always about a 3 or 4 or 5% cut in the last few years, and Congress has always fixed it, but they have to step in and do it. And that's why there's a desire to do something that's more long-term. And that is addressed in the sense of the Congress provision that's a part of the bill. Closer to kidney home, the Restore Protections for Dialysis Patient Act would undo the impact of the Supreme Court decision affecting insurance for dialysis patients. It would strengthen the Medicare secondary payer language to make sure ESRD services are covered. And, on the positive side, this would be a massive cost saving, so Congress could spend that money on some other year-end priority. But the insurance and the Chamber of Commerce community are advocating strenuously against the bill. So it's a tough advocacy fight, and I'll give more details on that in a little bit. So these are the broad issues that RPA has on its legislative agenda this year: living organ donation, telehealth, the community kidney bill, and promotion of staff-assisted home dialysis. So on living organ donation, you can see the name and the bill number there. It was introduced in February of 2021. This is essentially the same bill that's out there, been out there for a while, really addresses insurance issues with regard to living organ donation. There's great news in that this bill is really progressing, and there's cautious optimism that this might happen this year more than has ever been. And you can see the number of co-sponsors there. 43 co-sponsors in the Senate is really a great number, almost half of the Senate. And then with regard to telehealth, this is our preferred bill right here. It would address the originating site and geographic restrictions on use of telehealth in Medicare, do some other things. You can see the next 3 bullets, and I'll go to the last sub-bullet. It doesn't interfere with current home dialysis interactions. There are some bills that would remove the requirement for the nephrologist to see their kidney patient every 3rd month. We are opposing the removal of that requirement, and we think that's the home dialysis community trying to make that happen, which we oppose. But again, this is another bill with a lot of co-sponsors. And the funny thing with telehealth, it seems like every member of Congress has their own different piece of telehealth legislation. I think this is the most likely telehealth vehicle, but that is a bit of a crapshoot. We'll see what happens in the next Congress. With regard to the community CKD bill, what it would do would increase access to the Medicare kidney disease education benefit and expand the Medicare annual wellness benefit along with the other sub-bullets that you see there. The thing with this bill, it's never really expected to get passed by itself. It more serves as a platform for desirable provisions to make it into bigger bills. And we would think the KDE provision and the provisions are the ones that would probably make it into another year-end bill. You can see by the limited number of co-sponsors that it's not something that necessarily gets passed by itself, but it's something that will have provisions taken out of it to be included in a bigger bill. And then there's the staff-assisted home dialysis bill. You can see the bill number there, and this would pay for assistance by the staff of a dialysis facility to patients on home hemo and peritoneal dialysis. And the other bullets you see there, 19 House co-sponsors and no Senate companion. One of the positive things I think about this bill is that proponents have realistic expectations for it. Sometimes when these bills get introduced, people are like, we want this passed today. And that's not going to be how it works with this bill, just like it didn't work that way on the immunosuppressive drug coverage bill. It'll take multiple Congresses, but RPA believes this is the right thing to do, so that's why we're supporting the bill. Other legislative issues that are out there right now, the FY 2022 funding addressed a number of issues that we care about. KidneyX got $5 million and was flat funded. The NIDDK, the NIH Kidney Institute, got $2.2 billion, a 3.37% increase, and this was on par with all of the other institutes at NIH. CDC got $3.5 million for kidney disease surveillance and awareness, and living donor assistance. The commission for that received $7 million. There are prior authorization bills out there that would put put guardrails around insurance companies' use of prior authorization. It passed the House in September and has 45 Senate co-sponsors. So big numbers. I think most everybody thinks in whatever year-end bill happens, the prior authorization provisions will be included. And then there's something else out there called the Kidney Health Connect Act that would designate dialysis facilities as originating sites for telehealth with 2 and 7 co-sponsors respectively. I think the idea is that these issues will be addressed in the other telehealth bill. So it's kind of a moot point if that happens, but this bill is out there related to kidney health. Okay, with regard to Part B reimbursement, organized medicine is obviously going to be working hard on Medicare payment reform. You know, for the macro bill, reforms were always supposed to be necessary. And when it was passed, the idea was that it was underfunded. But if you listen to the AMA talk, they believe there's cuts on autopilot that need to be eliminated. And these include reductions related to sequestration, what's called PAYGO, plus the conversion factor piece that I talked about earlier. You know, what would we want to see in an improved Medicare payment system? Annual payment updates to cover practice costs and inflation, mostly inflation, viable future for alternate payment models that accounts for physician and patient satisfaction, and some sort of streamlined reporting. This will be a long fight. This isn't going to get resolved by the end of this year. It'll be a long time, but medicine's doing what it can to make things happen on this. With regard to the Supreme Court decision, Marietta versus DeVita, it would allow outpatient dialysis reimbursement to happen at out-of-network rates, and it rejected the proxy argument that ESRD equals outpatient dialysis. I think this was something of a surprising decision. Everyone who listened to the oral arguments thought they were in DeVita's favor. Corrective legislation was introduced in the summer, as noted previously. And again, as noted previously, this would probably be a whopper of a cost saver. Some people think it would be in excess of $1 billion. And this significantly increases the chances of enactment because, of course, Congress wants to spend that money on something else in a budget neutral system. But again, as previously noted, the insurer and Chamber of Commerce communities are actively opposing the bill. So we'll have to see what happens with that. So with regard to the kidney payment models, the ETC model, the ESRD treatment choices model, is currently in performance year 2. And the first PPA performance penalty adjustment true-up happened in July. So nephrologists and nephrology practices and dialysis facilities were finding out how they did. So where CMS is housing changes these days to the ETC is in the PPS, the ESRD prospective payment system that determines dialysis facility payment. And that's where they're putting these changes now. And in the 2023 rule, it did include minor ETC refinements. The voluntary models, of course, as noted, are underway after the March 2021 delay. The request for application for the second cohort was released in February, and applications were due in March. I can tell you, I talk to CMMI staff pretty regularly with regard to the payment models, and they're pretty happy with the response that they got from the RFA and generally how things are going broadly. So there's no other really big news coming out of CMS at the moment. So with regard to the immunosuppressive drug coverage rule, it was released in late April, and the final rule came out a couple of days ago. It was effective it will be effective January 1st. It allows verbal attestation of no other immunosuppressive drug coverage. Enrollment is to be based on attestation and prior participation in the ESRD program. RPA was pretty happy about this. We thought that it was about as painless a process as CMS could have created, so we supported them on that. And it's interesting. They talked in the rulemaking process about trying to make it as easy to use as possible was based on the Biden administration executive order on improving the federal customer experience. God bless them. As noted, our comments were broadly supportive. We did address some concerns that were out there for pediatric patients that we supported the American Society of Pediatric Nephrology on. So with regard to the Medicare fee schedule proposed rule, after last year's congressional action, the conversion factor was set at $34.60. CMS is proposing the cut that you see there, and that would be at 4.42, and that's where Congress got the number in the legislation where they're trying to fix this, and we have every expectation they will for the end of the year. So we'll see what happens with that. There is also a proposal to update clinical labor pricing inputs for 2023, and this is very bad for vascular access service in office-based settings. And the reason for this is the fact that It reduces payment for whatever practice expenses there are for in-office surgical procedures like vascular access services, and the money goes to primary care. That's what makes this challenging. CMS did implement this via a 4-year transition, about a 5% cut for these services for 2022, 20% over 4 years. Advocacy in this space continues. The problem with this is that it's kind of confusing with the conversion factor advocacy that's going on as well, so it's kind of hard to deal with. There's another proposal that would revise policy on split shared visits, but it was delayed until 2024, which we were hoping for. But CMS did say in the fee schedule rule they think this is an appropriate change. And it's based on what they call the definition of the substantive portion to base it solely on time, which we have rejected. We think that it diminishes the importance of physician decision-making, and all of organized medicine is fighting this very, very intensely. With regard to the values for dialysis services, they only changed incrementally this year, mostly upward, and it looks like it's going to be the same for next year. Nephrology goes up 1% for 2023. With regard to the ESRD prospective payment system proposed rule, it was set at $264.90, which was a 2.4% increase over this year. With regard to the mandatory payment model, the ETC, it did include a PPA modification to exclude bonuses in the 30th percentile for participants with a 0 score. Essentially, what this was saying is you shouldn't get credit if you have a 0 score in your PPA adjustment, which that's pretty hard to argue against. There was a proposal to prohibit leasing of staff from ESRD facilities for the purposes of providing kidney disease education services. The thought that this could avoid potential steering of those staff of patients to their facility. And at press time, the PPS, along with the fee schedule and the HOPS ASC rules, we're still waiting on everything. With regard to vascular access reimbursement, there was a small increase finalized for 2022. So dialysis circuit code services are projected to get about a 3% increase. There was something called a complexity adjustment that would pay for combinations of add-on codes, and add-on codes previously were never paid for in the ASC rule. So that's very positive for those codes, but otherwise it's been business as usual. With regard to telehealth and Medicare, all of the changes that happened in the spring of 2020 are still in place. But for how long is this going to be? The omnibus package from March of this year included a 5-month telehealth extension from the end of the public health emergency. But the question is, when does that clock start ticking? It could start as early as January 15th. Chances are it will be later. A lot of people think that this is going to go on well into 2023, and there's been advocacy, as I noted in a couple bullets down, that is seeking this to go until the end of 2023. It's become something of a political football because Republicans would like to end the public health emergency because there's a lot of safety net provisions that are included in that they don't think should continue to be funded outside of normal processes. Of course, Democrats think those things should be funded, so they're going to let that go if they can. And then with regard to the sub-public health emergency telehealth issues, there are issues like the status of audio-only services, the fact that you can get paid for phone calls in Medicare, which didn't happen before, interstate reciprocity, can you use telehealth across state lines, scope of practice and consistency of telehealth policy among insurers. Just to give a little outlook here, Congress is closed for the midterm elections, and D.C.'s a ghost town. The Schumer and Manchin pact on the Inflation Reduction Act was pretty stunning, and that kind of chilled bipartisanship in the Senate afterwards for a while. As usual, December will be very active, but affected by the election results. And if and when the Democrats lose any control in November, they will be racing the clock to achieve things before 2023. And the big issues on the health side will be Part B reimbursement, prior authorization, telehealth, and hopefully some of our kidney issues will get a ride on that bus. On the regulatory side, the rulemaking this year will be the first big indicator of what the Biden administration is doing. There will be a focus on health equity, as noted, and the unwinding, that's the word they're using for it, the unwinding of the public health emergency and impact on future telehealth is weighing heavily on everyone in DC's policy circles right now. As in recent years, we don't think the big fee schedule cuts are going to occur for physicians, but relief won't come from the regulatory process as per current law. Other issues that are out there that are bothersome, the clinical labor cuts and split shared service policy will be a heavy heavy lift to change, but there are a lot of groups that agree with RPA and organized medicine on this. So we think we might have some positive changes. And there's no reason to expect substantive change on the kidney payment models or what's going on with the dialysis facility payment. Although when you least expect it, something might happen. Okay, so there's my contact information. Please, I know I went fast here, so please contact me at the information that's here now, and I'll be happy to answer any questions. And you can follow me and RPA on Twitter. I tend to tweet in real time on RPA policy issues, or I should say kidney policy issues when they happen in real time. So if you're interested in that, give me a follow. And it's been a tremendous pleasure making this presentation for you. Many, many thanks to AAKP for the opportunity to speak to you. Good luck with all your advocacy and have a great holiday season.
Thank you very much, Rob. We appreciate what you do for patients and for our allies at the Renal Physicians Association.